Hi everyone, and very good morning to all of you. I hope that you are well, and especially all of my dear students who are preparing for this FMG and NEET PG. So this would be a wonderful session. We'll discuss all the PYQs. It's a randomly made PYQs, and if you want to assess how much you are prepared, do not just look at the questions and the answer. Ensure you also look at the explanations I'll do for these MCQs. Okay. So first of all, a warm welcome to all of those who have joined me live in this session. Hi Shubho, good morning. Anyone else who would acknowledge their presence? Yes, hi Ayush. So, any extra special thing that you would like to for me to cover up here? Please let me know. I have prepared this whole session considering the important question that have been asked in the last 5 years of NEET PG, NICT, and the FMG as well. So this would be a wonderful session for all of us to revise the questions as such. Hi Ayush, hi Ranjan, Videsh, Janvi, and Dr. Irresistible. Okay. Hi Akshay. So what I'll do is I'll show the questions initially, and I want all of you to answer those questions as you would know the answers to them, and then you look at to my explanation and whether my explanations matches to your knowledge or not. In case there is any gap in the knowledge, it's better you just fill up the gaps by writing it somewhere, or even though I'll share this PDF to you after the session is over in my own Telegram group as well as in the FMG group as well. But I would suggest you take out your just take out a copy and just note some important points that might be new to you as well. For those joining me again new, Dr. Vipul, hi, uh, Jaka, Rohini, and Masum Raj, hi, good morning everyone. So please share this link to as well everyone else also. Let's include some other friends as well in the discussion also. So this is the first question, and I want all of you to look at his pedigree as well. Okay, this pedigree is a bit hidden from my presence here, but no worries. I look at his pedigree here, and now which condition is inherited according to the given pedigree? Look at his pedigree here. Yeah, I want all of you to just put your random answers. Uh, so yes, answer is B. Okay, Wiskott-Aldrich syndrome. So how did you guess it? This pedigree looks to be a X-linked recessive disease. How? That's an important question. So how do you think it's X-linked recessive? So therefore, when you solve a pedigree, you should have the three rules. The rules of pedigree, there are three of them. The first one is rule of dominance. Okay. So what is this rule? In this rule, you have to see if one of the child is diseased, okay, and child's one of the parent is diseased, okay. That means if if child is diseased and then you see one of the parent diseased, okay, then you see one of the parent diseased, child diseased है and one of the parent also diseased, it means it is dominant. Okay, ये rule number one है. The rule 2 says that if you look at the X-linked disease, so rule says that the males would never transmit to son, okay, but male would always transmit to daughters. This is the for X-linked rule. And the third one is look for mitochondrial. In mitochondrial, only mother can transmit, but mother would transmit to all children without any exception. The mother would transmit to all children. This third one was also the MCQ asked in last FMG in the January session. I saw this question also being asked about the mitochondria. So now when we have the three rules, we can just apply the three rules here into this particular pedigree here. Dekho. So as you understand, this particular is carrier. Now the point is the carrier state, it can never occur in the dominant diseases, correct? Because carrier can never occur in dominant diseases, this question straight away becomes what? recessive, right? So this becomes recessive altogether. Now you have to look for whether it is autosomal recessive or is X-linked recessive, right? Recessive तो है ही. So how to guess to know it's autosomal recessive or X-linked recessive? The way is, look at this one. Disease child है, okay, and this carrier हो गया recessive. Now look for the diseased males. देखो, when you look at the diseased male, the daughter is a carrier, the son is normal, right? So what you see, the daughter is a carrier, son is normal, it means it is X-linked recessive, cannot be autorecessive. Because had this been autosomal, then the male would have transmitted also to son. Male should have transmitted also to son. It is not happening here. And therefore the disease is what? It's a X-linked recessive disease. Now some of you are saying, like Ranjan is saying, कि sir, mother can transfer. Agreed. Please समझो एक बात. The mother can transfer, but please understand, carrier state doesn't occur in mitochondrial. Mitochondrial matlab it will be diseased or not diseased. Hence you cannot say carrier here. समझ आ रहा है? देखो, you are saying mother is transmitting and hence you are thinking it's mitochondrial. First of all, it cannot be mitochondrial for two reasons. Number one, carrier state cannot occur in mitochondrial. ये first condition है. Second condition is, had this mitochondrial, the mother would have transmitted to 1, 2, 3, 4 all children. Is it happening? It's not happening there. Hence it is not mitochondrial. Clear हो रहा है सबको? Is it clear? अच्छा. So now if it is X-linked recessive, now look at the conditions here. The first condition is autosomal recessive. What is it? Wilson disease. Wiskott-Aldrich being the answer is X-linked recessive, and Prader-Willi syndrome is what? Mitochondrial. Achondroplasia is what? Autosomal dominant. But remember, achondroplasia also follows something called as germ-line mosaicism. Okay, mitochondrial also follows the germ-line mosaicism. ठीक है? अब what is the way to remember all these diseases? देखो, I would give you a simple way out how to remember all these diseases in a simple way, and I can try to recall all of this from a mnemonic point of view. Okay, so my mnemonic for all of this would be very simple. I'll show the mnemonic here. रुको. Yeah, so I'm just moving into my own notes of the FMG, and I'll straight away move to the genetic disorders, and I'll show you some of the disease which should be remembered here. Okay, देखो. So in the X-linked recessive disease, the mnemonic is Lady Harding College girls don't care about foolish words. Now I want all of you to recall this one because it's very very important. Because if you remember the X-linked recessive, others become very very simplified. देखो, Lady Harding College girls मतलब लेशनियन syndrome, Harding से hemophilia hunters, C से CGD chronic granulomatous disease, G से G6 PD deficiency, D is Duchenne's. ये बहुत इंपॉर्टेंट, सच अ फ्रीक्वेंटली आस्क्ड क्वेश्चन का है, Duchenne's. C is color blindness, A is agammaglobulinemia. If you remember the whole name, it's called Button's X-linked agammaglobulinemia. F is fragile X syndrome, and W is our answer here, Wiskott-Aldrich syndrome. ये है X-linked recessive disease. About the X-linked dominant disease is red rose for all children, rickets, Rett's, Fleck syndrome, Alport syndrome, and Charcot-Marie Tooth disease. ये है X-linked dominant disorders. About the autosomal dominant, the mnemonic is heavy dominant. The mnemonic is heavy dominant, and the heavy dominant is hypercholesterolemia, hereditary spherocytosis, HNPCC. HNPCC is a frequently asked question. E, Ehlers-Danlos syndrome, except type 6. Okay. APC, you all know this, adenosis polyposis coli, the multiple polyps that happen in intestine, that one. Von Willebrand disease, again a very frequently asked question. Heavy, the Y is the Y of hypoparathyroidism, it is pseudo hypoparathyroidism. अब देखो, this can confuse you. Dystrophica myotonia जो है वो autosomal dominant है. All of you please look here, do not forget this. Okay, I'm just marking this here, all of you. देखो, Dystrophica myotonia is a autosomal dominant, whereas Duchenne's is a X-linked recessive. Now this question is very frequently asked. Okay, now come back here. Osteogenesis imperfecta, Marfan syndrome, intermittent porphyria, very frequently asked. क्यों? Because the porphyria usually is not autosomal dominant, it's autosomal recessive, but intermittent porphyria is autosomal dominant. Okay, NF1, NF2, achondroplasia with adult polycystic disease of the kidney, Noonan syndrome. Why important? Because Turner syndrome findings, if it's following a Mendelian law. Turner syndrome, if it's not following the chromosomal law but is following the Mendel's law, it is called as Noonan syndrome. But do remember, Turner syndrome has mental retardation. Noonan syndrome does not have mental retardation. याद रहेगा सबको? Okay, and tuberous sclerosis. Now do remember, among these, three of them, I'm making a star mark. All of you look here. देखो, osteogenesis imperfecta, okay, achondroplasia, and tuberous sclerosis. The three here will also follow what? Tell me, all of you. Can anyone tell you? Tell me, among these three, even though they are autosomal dominant, they also follow one more rule. Who can tell me this? Tell me. Who can tell me these three follow one more rule? Which rule? Waiting for answer. The answer is germ-line mosaicism. The answer is germ-line mosaicism. ठीक है? Got the point, all of you? चलो. The first question is done. Okay, chalo. Which of the following is not true about von Willebrand disease? Tough one. Tell me the answer though. Guys, share the link to your friends also so that they can join and can benefit from the discussion that we are having. The most important part is discussion. Questions, so you all know. Discussion is more important here. Okay. Okay. So tough one. I told you na. Today's MCQ is not an easy one. कि question देखोगे, answer देखोगे. You have to listen to me very carefully, and no one will leave this video before 2 hours. 2 घंटे का रहेगा. We'll discuss many questions here. देखो. So now we have VWF. ठीक है? What is VWF? First of all, VWF, it has two functions. One, it causes addition of platelets more than aggregation. ये first function है. The second function you should know is it stabilizes factor number 8. ठीक है? Two functions है. Because stabilizes factor number 8, it also increases APTT, but only. Doesn't increase PT, it increases APTT only. Now, VWD, von Willebrand disease, VWD, this I just told you is autosomal dominant, remember? But do remember, VWD is of three types. Okay, is type 1, type 2, and type 3. Okay, type 2 has some subtypes, which is not important for us though. So type 1 and 2 may remember, type 1 is the most common and is autosomal dominant, 2 is autosomal dominant, third is autosomal recessive. What happens in type 1 is it's a mild deficiency. Okay, 3 is a severe deficiency. Okay, and 2 is a qualitative defect. Okay, now understand one important point. देखो, as a rule of genetics, the rule of genetics says that if any disease is autosomal dominant, सुनो बात को, if any disease is autosomal dominant, the age of presentation is never born, is never at birth, is often at childhood or adulthood. So that means age of presentation would be childhood to adulthood. Okay. However, if a disease is recessive, then it is occurring at birth. Now sir, how to remember this? देखो, do you remember something called as inborn error of metabolism? सुना है सबने? Inborn error metabolism you read in biochemistry or in pediatrics. नाम क्या है उसका? Inborn error मतलब at birth it manifests. And if you remember the rule says all inborn error of metabolism is autosomal recessive, right? So now understand this part and come back to the previous discussion. देखो यहाँ पर VWD type 3 has severely low WWF. Is true statement. ठीक है? Type 1 is the most severe disease in the children. No. So type 3 is the most severe form. ठीक है? Next. Type 3 is the most severe disease in children. Yes, that's true. Okay? And type 2 is seen with moderate bleeding deficiency. Type 2 is surely seen with moderate bleeding deficiency because it is having a qualitative defect. Okay? Acha. Now, if you understand this part, we'll also discuss how do we confirm VWD. Okay? So, confirmation of a VWD comes from a test called as ristocytin agglutination type. Okay? The confirmation of VWD comes from ristocytin agglutination type. Okay? And what test is increased, sir? APTT only is increased here. ठीक है? चलो, all of you, we move to next question, guys. Okay. Yes, the answer is BRAF with V600E. What is this one? देखो, now look at this part. अच्छा, tell me, does thyroid look like this? No. How does thyroid look like? पहले वो देख लेते हैं. It becomes more easier that way. So for that, I'll straight away take you to the Google. वहीं चलते हैं. And let's see the thyroid histology. ठीक है? देखो. This is how the thyroid gland looks like. देखो. Beautiful looking thyroid gland. Look at this one. These are follicles. Follicle के अंदर these are the colloid area. You know the blue cells. देख रहे हो these blue cells. All the blue cells you see here are follicular cells. Okay. And between the follicle cells, we look at this part. It's a parafollicle C cells. The parafollicle C cells releases what? Yes, releases calcitonin. ये क्या है? Colloid. ठीक है? अच्छा. Now compare this image to the one shown in our MCQ. ये देखो, does it look like thyroid gland? No. What has happened is, look at the long structures like a papilla. देख रहे हो? Look at this one. Is the papilla like this? Look at this one. Look at this papilla. Look at this long projection like this. This all finger-like projection is called as papilla. Okay. So what we can say, the first thing happening in this part is papilla. So if you see a thyroid gland with papillary projections, papillary projection, it is called as papillotheroid carcinoma. Papillotheroid carcinomas. Clear हो रहा है सबको? अच्छा. So now before I move to the tumor of this one, let's discuss in short how will the other glands look like, how will the other structures look like. So again, I'll take you to the my FMG workbook only, and let's discuss the important aspects of this gland here. देखो, देखो. So what we see in the papillotheroid carcinoma are the papilla. What we see in follicular carcinoma is the follicles invading capsule. तो I'll show the image better. वो तुमको better समझ में आएगा. ठीक है ना? Let's see the image only. देखो. तो when I show you a follicular carcinoma, ठीक है, of thyroid, then what happens? Look at this image. पहला image देख लेते हैं. तो this is the capsule. This is the follicle, and see how beautifully the follicles are invading capsule. देख रहा है सबको? Is it clear for all of you guys? The follicles here are invading capsule. Because the follicles are invading capsule, it becomes what? Follicular carcinoma thyroid. कितना सिंपल है. अच्छा, now sir, can you also show me Melry carcinoma? अरे that's very easy. देखो, what do you expect to see in Melry carcinoma thyroid is number one, you expect to see is a amyloid. क्यों amyloid? Think, these all pinkish amorphous deposit here is what? Amyloid deposition. तो सर why and from where has amyloid come here? एक क्वेश्चन होना चाहिए ना. देखो, Melry thyroid carcinoma comes from the parafollicle C cells, and the parafollicle C cells make what? Calcitonin, which is depositing as what? Yes, amyloid. तो all this pinkish area क्या है? It's amyloid deposition. ठीक है. Let's now see again the papillary carcinoma image. ठीक है, चलो all of you देखो. So what happens in papillary carcinoma thyroid is a unique thing. Like look at this image. I think all of you can appreciate the papilla here. ये देखो, long papilla like this, and papilla के inside में this pink area is not the colloid area. ये vessel है. But now look at this cell here. देखो, this round cell, and round cell has white area in between this. Appreciate कर रहे हो ना? This white area. Look at 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 this white area. अब ये जो white area है, this white area, ये वाला, this white area, this one, है ना? This white area actually is looking like the eyes of this girl. This girl name is Orphan Annie, right? From which the name was derived? The name derived is Orphan Annie I nuclei. Name क्या है? Orphan Annie I nuclei. This is the nuclear hallmark feature of papillary carcinomas. Which means what? It means if you can look at this girl's eye, okay, like nucleus, it confirms the case. It's papillary carcinoma. How to confirm this? By either FNAC, or you can confirm this by biopsy. So I'll write all this finding in a image format, in a simple table format for you in this notes. देखो. So we have got PTC, FTC, FTC, MTC, ATC. सर ये क्या लिख दिया? तुम बताओ क्या है? पैपरी कार्सिनोमा, फॉल्कर कार्सिनोमा, मेलरी कार्सिनोमा, एनाप्लास्टिक कार्सिनोमा. ठीक है. अच्छा, सबसे मोस्ट कॉमन कौन सा? मोस्ट कॉमन. ठीक. सेकेंड मोस्ट कॉमन, 5% रेयर. क्लियर? अब आ जाओ ऑरिजिन. ऑरिजिन इज फॉलिकल सेल्स, फॉलिकल सेल्स, parafollicle C cells. This one is undifferentiated. चलो, mutations. What mutation in PTC? BRAF. ये है BRAF mutation. ठीक है. FTC में RAS gene mutation. Okay. And everywhere will come P53. वो तो हर जगह रहता है. But RAS is very important along with PI3 kinase. MTC में RET RET gene mutation. अच्छा, याद रखना, रेट म्यूटेशन इज सीन विद मेन सिंड्रोम. हु विल टेल मी रेट जीन इज सीन विथ विच मेन सिंड्रोम? बताओ तो मुझे, टेल मी. एंड ATC विथ P53. ओके, रेट जीन याद आया? यस सर, याद आया. मेन 2A and 2B. ओके. नाउ द बेसिक माइक्रोस्कोपिक फीचर्स. PTC shows what? You make a papilla like this, ऐसे. ठीक है ना? ऐसे पैपिला बनाएंगे, लॉन्ग लॉन्ग पैपिला. इनसाइड द पैपिला डॉट ट्यूमर सेल लाइक दिस, ऐसे. ठीक है. व्हाट आर दिस ट्यूमर सेल शोइंग? इट्स अ ऑर्फन एनी आई न्यूक्लियाई, एंड इनसाइड दिस सेंटर में बनाएंगे वेसल विद RBC इनसाइड इट. ठीक है. इट कैन बी कंफर्म्ड ऑन FNAC ऑल्सो प्लस बायोप्सी ऑल्सो. बोथ कैन कंफर्म दिस. क्लियर? वेरी गुड. 2A 2B. तो तुम लोग मस्त प्रिपेयर्ड हो यार. रंजन, सुवो, आयुष एंड अर्शिया. परफेक्ट, वेरी गुड. FTC देखो. इन FTC दिस इज अ कैप्सूल. ओके, ये कैप्सूल है. इफ दिस इज अ कैप्सूल ऑफ थायराइड ग्लैंड, व्हाट वी कैन सी इज द फॉलिकल्स आर इन्वेडिंग कैप्सूल लाइक दिस, ऐसे. द फॉलिकल्स वुड इन्वेड कैप्सूल. ठीक, क्लियर हो गया? राइट. इन्वेजन. कैन यू सी इन्वेजन? Can you see invasion on FNAC? No sir. Cross mark करो. In biopsy? यस सर, टिक मार्क करो. क्लियर. अच्छा, नाउ एमटीसी. एमटीसी में यू सी व्हाट, ए सेलुलर ए कैल डिपोजिशन, ए सेलुलर ए कैल डिपोजिशन. ठीक है, दैट्स व्हाट amyloid. And along with amyloid, remember, it's a nests of tumor cells. Why nesting pattern? Because ultimately, if you remember, the MTC which comes from C cell is nothing but a neuroendocrine tumor. It's a net. It's a neuroendocrine tumor net. So which shows what? A cellular amyloid deposition. And the fourth one is what? ATC. ATC क्या होता है? Anaplastic. Right? Anaplastic carcinoma means it's a undifferentiated anaplasia. And you all know anaplasia means poorly differentiated tumor. So how would you differentiate this one, MTC, if you see this type of a cellular amyloid deposition, and between this you see the parafollicle C cells ka nests. Remember, the parafollicle C cell nest would be spindle shaped tumor cell nesting pattern. ऐसा elongated cells होंगे. I will making nesting pattern like this. So if you make multiple nests, ये one nest है, you make one more nest, suppose, sorry, if you just make some more nests here, ऐसे, this is how this will appear. Nests with amyloid, nest रहेंगे with amyloid, ये बन गया MTC. So this is a very very short tailor drawn for you for discussing all the types of thyroid carcinomas. Perfect है. चलो next one. Answer. Yes, very good. Answer is C. Perfect. Chalo. A patient presents with abdominal pain, hepatosplenomegaly, WBC count of more than 50,000. Okay. With neutrophilia and basophilia. Which of the following genes is involved in this case? So question क्या है देखो. The question says pain abdomen है with hepatosplenomegaly and there's a high WBC count. There is neutrophilia and there is basophilia. Neutrophilia भी है, basophilia भी है. It whole thing is going in favor of what? CML, chronic myeloid leukemia. Now look at the question. In chronic myeloid leukemia, we see the PH chromosome which has translocation of 9 with 22. Very good. PH chromosome with 922 translocation. Very good. So now let's discuss some important things about chronic myeloid leukemia. Very very important topic. देखो. So what we should know in CML first of all is its mutation. The mutation you often see in this chromosome is PH chromosome, which is 922 of long arm 34 and long arm 11. Q34, Q11. Okay? The PH chromosome will make a protein of P190, P210 and 230. Among the three proteins, remember, the most common one is 210. The most common. Okay. Now this most common occurs in CML. 190 is seen in ALL and 230 shows neutrophilia. Now sir, what is this number written there? The small p is protein and the number is actually molecular weight in kilodaltons. Okay, in kilodaltons. Kilodaltons. Now, what happens is, if you look at the three proteins here, 190, 210, 230, among this the most common and seen in a case of a CML is 210. Clear first question? Now remember, in the peripheral smear, it shows something called as a garden party appearance. Very important question. A garden party appearance has left shift. Okay, left shift. So what we should do when you get this garden party or left shifting is, we should look for the next test. And what is the next test, guys? leukocyte alkaline phosphatase or a neutrophil alkaline phosphatase score, LAP or a NAP score. This LAP or a NAP score ranges from 0 to 400. Okay, where if the score is less than 25, we call it low LAP score and seen in CML. A score of more than 125 is a high LAP score and seen in a condition which we make this is like the leukemoid reaction. Leukemoid reaction. Okay. Now, suppose you get a low LAP score and now your thought process is going towards CML, then you need to confirm this. And the confirmation comes from the fish analysis. We can do karyotyping, and for looking for the molecular weight of the protein, we can do polymerase chain reaction. But if the question is most sensitive, most specific, and then the best test, the answer is fish analysis. Okay, the answer is fish analysis. Okay, now let's discuss the treatment here. The treatment for CML is the tyrosine kinase inhibitor. The first line TKI is imatinib. Okay, if it is not working, in that case we should add the second line TKI, which is like dasatinib, ponatinib, bosutinib, and nilotinib. All the four categories can be given in this case, but the first drug always should be imatinib. It's about CML, chronic myeloid leukemia. In short, I'll discuss you everything which you require to know in a case of chronic myeloid leukemia. बहुत ही frequently asked question है CML. Okay. चलो next question guys, बताओ answer. Yes, Mr. Foodie. Good. It's adenocarcinoma. Very very good. देखो 55-year-old chronic smoker है. Okay, chronic smoker presents with weight loss, hepatitis, and TTF1 positivity. Okay, and TTF1 positivity. So what it can be with the TTF1 positivity, it has to go in a favor of adenocarcinoma. ठीक है. Now the question is कि सर I saw smoker. अब किसने कह दिया कि smokers can't have adenocarcinoma? कोई रूल है क्या? रूल नहीं है. The rule says the most common lung cancer in smoker is squamous cell cancer. Small cell cancer occurs only in non-smokers. Adenocarcinoma occurs in non-smokers, more common than smokers. But the moment you see TTF1 positivity, no, TTF1 is not tissue transforming factor. TTF1 is not tissue transforming factor. TTF1 is thyroid transcription factor. Okay, it's thyroid transcription factor. Sir, how can this come positive in lung cancer? Bhai, mutation hai, mutation. It's all about mutation, which is abnormality. So studies have shown that adenocarcinoma lung shows a TTF1 positivity, which is suggesting of a mutation. This mutation occurs especially in adenocarcinoma lungs. ठीक है, चलो तो can we have a short discussion on the lung cancer, guys? सब लोग confuse कर गए इस question में, right? So this is what the today's question is. It's all about thought. Memory से नहीं बनेगा आज का question कि पढ़ा था. No, thought process बनेगा. चलो, let's now discuss most lung cancers. So all of you, a short discussion on lung cancers. Two types. One is non-small cell cancer and one is neuroendocrine factor. Okay, non-small cell cancer and a neuroendocrine tumors. Non-small cell cancer has two types. One is a squamous cell carcinoma and one is the adenocarcinoma. Neuroendocrine tumor is a two types. One is a benign nature and one is a malignant nature. Okay, benign nature and a malignant nature. So, important points here. First of all, the most common answers. देखो, the most common in smoker is squamous cell cancer. Most common in India. Most common in worldwide. Most common in non-smoker. Most common in young age is all about adenocarcinoma. ठीक है? The benign nature of the net has an example of carcinoids. The malignant nature is atypical carcinoid, okay, and small cell cancer. Atypical carcinoid and a small cell cancer. ठीक है? Let's now look at the mutations. देखो, mutation of a squamous cell cancer. Squamous, याद रखना. Mutation of a squamous cell cancer is a P53. Okay, adenocarcinoma is KRAS, and they also have EGFR mutation. Okay, now about the important finding that will help you to solve the question. A squamous cell cancer clinically will show 2C. What 2C? One is a calcium increasing and one is a cavitations. Okay, now look at the IHC which helps us in diagnosis. The IHC for squamous cell cancer is P40, P63. The IHC for adenocarcinoma is two of them. One is the TTF1 asked in this question and one is a napsin. Okay, TTF1 and napsin. Yes, P53 can also come positive here. Now coming to the here. So in this one, for both of them, the IHC is same. And what is IHC? Synaptophysin. Okay. Chromogranin are the two important IHCs. Some others, if you can remember, it is CD56, INSM1, and can be NSC, that means neuron specific enolase positivity. NSC which means neuron specific enolase positivity. तो ये clear हो गया सबको? This is the basic tumor you must remember in the case of lung cancer. Okay, if you add up the microscopy, it becomes a pretty complete diagram altogether. You want the microscopy feature here to be added? Should I add the microscopy feature also? So in this one, it is keratin pearl. This one is a malignant glands with mucin. This one shows nesting pattern, and the small cell cancer shows azopardy effect. Azopardy effect. Okay, this becomes a concise way of revising lung cancer. Okay, among this, if the question is best prognosis, answer है adenocarcinoma. If the question is worst prognosis, answer is small cell cancer. Okay, among this, if the question is which can show carcinoid syndrome, all neuroendocrine tumor can show carcinoid syndrome, which is nothing but diarrhea, flushing, cyanosis. Okay, diarrhea, flushing, cyanosis. Okay, this is about lung cancer. Chalo, next one. Answer. You have to identify the microscopy here. Yes, very good. It's chromophobic RCC. कैसे देखो, तो have a look at this image. What you see in this image is, देखो, this is basically a cell. Okay, these all cells have a blue color nucleus like this, and around this a pale pink area. Around this a pale pink area is a finding of chromophobic. Pale मतलब less colored, less मतलब chromo मतलब color, phobia, color से phobia हो रहा है. Okay, it's chromophobic RCC. तो let's now see how will the other RCC look like. ठीक है, देखो, तो let's see first of all the other RCC here. देखो, first one is clear cell carcinoma. In the RCC, have a look at this part, and look at this part is a normal part of the kidney, and have a look at this part. Okay, so what you see here is a clear cell carcinoma, and see how the clear cells are arising. देख रहे हो, these all cells have a clear area here. इतना clear है, you can't call it chromophobic. had been chromophobic, उसमें होता less light pink color. ये तो बिल्कुल clear है ना, it's a clear vacuole. Hence we call this clear cell cancer. Look at some other images also clear cell cancer. Okay, so now it becomes a clear cell cancer. Look at this one, एकदम clear हो जाएगा. There's no color at all. It's completely cleared. It's a clear cell cancer. Now compare this image to the image I have shown you. देखो ये वाला, it's not clear. ये pink दिख रहा है, but less pink है. Because less pink, it becomes what? Chromophobic. समझ में आ रहा है? Just look at this one. ये देखो, clear दिख रहा है, full clear. So when you see a clear cell, it's a clear cell cancer. Okay, but when you see a light pink area, light pinkish area, it's called plant cell appearance. It's called as chromophobic cell carcinoma. Okay, now what's left out is the papillary carcinoma. So what we expect in papilla, you all know now, the papillary carcinoma of the kidney. Papillary carcinoma of kidney would show you papilla. ये देखो, now look at the papilla. Now so papilla कहाँ है? Look at this whole process. देखो how long the process is. देखो यहाँ से आ रहा है like a finger. How long the finger is. ये देख रहे हो, this whole finger. Inside this finger, this lightish area is a macrophage. Okay, but this whole thing is looking like a finger-like process. Look at this how long finger. If it's finger देखो, just trace the finger. देखो finger. ये देखो कितना long finger है. देख रहे हो, so long finger here. Hence what is it? It's a papillary cell carcinoma. So I think there's no doubt here. It's very simple, right? So let's write this whole story in the RCC. What we need to know. So in a RCC, first of all, remember the single most important etiological risk factor is smoking. Okay, and there's also aniline dyes. Okay, now RCC can be clear cell cancer. It can be papillary carcinoma. It can be chromophobic cell carcinoma. ठीक है, अब among these three, the most common is clear cell cancer. ठीक है, the second most common is papillary, and less than 5% is chromophobic. Okay, now clear cell cancer mutation wise is a VHL on 3P. Papillary cell carcinoma is MET gene. It shows trisomy of 7, 17 and chromosome Y chromosome loss, and chromophobic carcinoma, it shows the multiple chromosome loss. Multiple chromosome losses are seen in the chromophobic carcinoma. Among these, if you look at the prognosis, this one has the best prognosis. These two have intermediate. This also is intermediate. Okay, now about the microscopy, this shows clear vacuoles like this. Okay, the clear vacuole means nucleus being pushed to the periphery, and you can see a clear vacuole. When you see clear vacuole, the clear vacuole is basically composed of okay, is clearly composed of the lipids plus glycogen. Lipids plus glycogen. Papillary cell carcinoma has papilla like this. Okay? Inside the papilla is a macrophage, and they don't have orphan any. वो मत बना देना. Don't draw orphan any. Okay? They'll have dark papillary cell like this. Because of dark papillary cell like this, they call it chromophilic also. Some books call it chromophilic variety. Okay? This is also called as chromophilic variety. Okay? Now about the chromophobic carcinoma. The chromophobic carcinoma, it has the cell that you expect to be like this, assay. Now the important point is they will not have clear vacuoles. Nucleus will be in center only, and the staining will be light pink. ऐसे light pink staining, बिल्कुल light pink staining. Okay, ऐसे. They can be sometimes halo also. They can be halo also like this. This type of tumor, a light pink staining, is called as chromophobic carcinomas. Okay. Now among these four, we can add one more information called as Bellini. Now Bellini carcinoma, it has both of them as a collecting duct, because this one arising from the PCT. This comes from DCT and PCT both. It comes from collecting duct. That's the origin. The fourth one is called as Bellini carcinoma, which comes from collecting duct and has the poorest prognosis. Okay, and it's adding one more, Bellini duct carcinoma. Okay, this tumor has the worst prognosis. They also come from collecting ducts. Okay, that's in short about RCC. Chalo, let's move to the next question. Yes, answer. So patient has vomiting है, diarrhea है, and skin eruption history है. But in the past, after switching to gluten-free diet, symptoms has got resolved. ऐसे कैसे हो गया? Because it is nothing but celiac disease. So what test to do? Yes, it should be anti-TTG. It should be anti-TTG antibody. देखो, आस का एंटीबॉडी कहाँ करते हैं? इन क्रॉन डिजीज, CROHN, क्रॉन डिजीज, क्रॉन्स. ओके, अंका is C अंका, P अंका. We do this in POSI immune vasculitis. Okay, and the parietal cell antibody is done in pernicious anemia. So the answer is anti-TTG antibody. Let's now discuss some important points about this disease. देखो, celiac, again such an important disease, guys. Celiac disease, it's a hypersensitivity to gluten. Which is in bro. A bro means barley, rye, oat and wheat. Bro हो गया. Now occurs in those patients who have a HLA polymorphism of DQ2, DQ8 and B8. क्लियर हो गया? नाउ celiac में the antibody you see here is IgA antibody. So IgA type of anti-TTG antibody, IgA anti-endomysial antibody, and IgA type of anti-gladin antibody. Okay. Now among these three, remember, the TTG antibody is the most sensitive antibody. First question. And this antibody often cross reacts, CR mother cross reacts with the dermis antigen, causing dermatitis herpetiformis, which is a pruritic rash. Pruritic rash. Okay. Anti-endomysium antibody, anti-endomysium antibody. This is the most specific antibody. Gland antibody is the second most specific antibody. Okay. So now this is the initial diagnosis. We can call it screening disease. But when we need to confirm this, for confirmation we take a duodenal biopsy, and inside we do Marsh reading system. To understand this biopsy, I'll just make two diagrams to make it very simple. Dekho. What happens is, if this is a villi and crypt, villi and crypt, villi and crypt, normally, okay, normal hai. So what happens, the villi is almost lost and the whole thing becomes flat like this, and the crypts can be retained like this. In fact, the crypt also elongates sometimes. That means there's elongation and hypertrophy of ratio of the crypts like this. Along with that, there is the blue cells, huge amount of lymphocytes you see here. Okay, that means three things you expect to see here. Dekho, please understand this part. This is the villi. Okay, ये क्या है? Crypts. So what do you see here? Number one, loss of villi. Second is crypt hyperplasia and elongation. Hyperplasia means increase in number, and elongation, as you can see in the image clearly. And these are the lymphocytes. The lymphocytes can be T lymphocytes but also B lymphocytes. So when you have this 1, 2 and 3 things being added up in the histopath report, the whole thing is called as Marsh grading system. Marsh grading system. Okay. Secondly, the question can also be asked, ये तो हुआ celiac, a disease which is almost like celiac, almost, but is not due to gluten diet. It is environmental enteropathy called as what? Yes, it is called as tropical sprue. Tropical sprue, I'm writing it here. Tropical sprue, it is almost like celiac, but the etiology you see here is actually Escherichia coli with Giardia. And therefore, the treatment here is not gluten-free diet, obviously. It is antibiotics. And do remember one important thing, that the folic acid often improves symptoms. Folic acid often improves symptoms. This is what you should know about celiac. सबको याद रहेगा इतना कुछ? अच्छा. If I add one question of dermatology, so in this one, if you look at the skin biopsy, especially of dermatitis herpetiformis, the fluorescence would be seen as the dermal tips. Dermal tips will show you IgA deposition with papillary tip necrosis, and that finding is referred to as dermatitis herpetiformis. ये वाला. Okay, DH. Perfect. Chalo, next question, all of you. Next question, guys. Answer. या सॉस्टिक B6 दे सकते हैं एंड फॉलिक एसिड, बोथ विल हेल्प टू इंप्रूव सिम्टम्स. फॉलिक एसिड इज मोर इंपॉर्टेंट. ओके, look at this image. This is 1, ये 2 है, 3 and 4. Yes. So what is diagnosis? देखो, a 2-year-old child is brought to the OPD and mother complains of child not feeding well, bilious vomiting. ठीक है. Child is diagnosed with congenital megacolon. A canonic segment of the colon is shown here. So what is the disease? It looks to be Hirschsprung disease. Okay, ये लग रहा है Hirschsprung disease है. तो Hirschsprung disease has abscess of what? It has a gangliosis. But do remember, ganglion कहाँ होता है? So let's understand what is Hirschsprung disease. Very very important question for you all. देखो, Hirschsprung disease actually is the congenital agangliosis. It happens due to loss of RET, red gene. Red gene is on chromosome number 10 long arm. It causes a premature arrest in the descent of neural crest cells. Okay, because of the premature arrest and descent of neural crest cells, what would be there? There would be the distal segment. Please remember, the distal segment would become aganglionic. Okay, the distal segment will become aganglionic. Okay, now the question is, sir, if it becomes aganglionic, then which ganglion is absent? 2 ganglions. देखो, what ganglions we should know? The layers are mucosa, submucosa, okay, muscle layer and serosa layer, right? The 4 layers होते हैं. अब understand कि ganglion are derived from neural crest cells. Okay, however, in the submucosa, the ganglion name is Meissner, and muscle has Orbach and Mindtrick. These are all ganglions, G's ganglions here. Mucosa does not have any ganglions. The ganglion is only in the submucosa and also in the Orbach and Mindtrick plexus. ठीक है. अब if you look at these 4 points, let's come back here. ये देखो. अब in this image, please understand this pinkish lines, ये muscle layer है. Okay, below the muscle layer is serosa, above the muscle layer ये जो layer है ये submucosa है. Okay, ये submucosa है. But if you ask me, sir, I am getting confused into these layers. That's your question, right? अब देखो, do you all understand that this layer here, देखो, हाँ देखो सब लोग, don't look here and there, यहाँ देखो, this layer here is almost same as this layer. This layer here also looks like muscle layer. Okay, but this layer is above this submucosal layer, but looks like muscle. So I will call this layer as muscularis mucosae. क्या बोलोगे? Muscularis mucosae. तो layers of mucosa क्या क्या होते हैं? Lining epithelium, lamina propria and muscularis mucosae. Below this is the submucosa layer. Below submucosa is a muscle layer, and below muscle layer is serosa layer. So now I'll show you one more diagram of the intestine. One more image देखते हैं, so that all the confusion can be removed today. देखो, intestine layers. Histo. ये देखो. So in this image, look at this part. From the top part here, and when you move up to this part, this whole part is mucosa. ठीक है. अब mucosa देखो, this dark pink layer, देख रहे हो, this dark pink layer यहाँ जा रहा है, ये वाला, ये देखो, ये वाला, this dark pink layer, ये वाला दिख रहा है, ये layer, this one, this layer दिख रहा है सबको. This is the muscularis mucosae. This is the crypts. Okay, जो glands कहते हैं हम लोग crypts कहते हैं basically. And this pinkish area is lamina propria layer. ये जो lining है, this is lining epithelium. देखो lining epithelium है, which plenty of the cells, goblet cells, because this is a large intestine I'm showing you. It has to be goblet cell actually. This is a layer of यहाँ से यहाँ तक, this whole layer is mucosa. ठीक है. अब now look at this part. This part is submucosa. Clear हो रहा है सबको? And now look at this part. ये muscle layer है, ये serosa layer है. अब ganglion is present in this layer, submucosa, which is what? Meissner. And between these two layers, what is that? Orbach or Mayentrick. So now comes the question, sir, what happens in Hirschsprung? Hirschsprung में submucosa and the muscle both are actually gone. Both are gone. This is how the whole thing is there. कितना सुंदर इमेज है. Mucosa, muscularis mucosae. This whole thing is mucosa layer now. ये submucosa है. Okay. This is inner circular, outer longitudinal. Both are muscle layer. And between these two, यहाँ पर होगा one more ganglion. This ganglion between these two is called as Orbach or Mayentrick. Is clear to all of you? So now based on this finding, therefore the answer here becomes what? 2 and 3. Layer 2 and 3. बोलो क्लियर हो रहा है सबको? चलो अब क्लियर हो रहा है? Then just put a like on this video and please share to your friends so that they can also join up here and they can discuss. देखो please understand, question is not important. My discussion is more important because the chance of exactly this question being asked is less, but the chance of this discussion being asked is very very high, very very high. इसीलिए put two things. एक इसको फटाफट like short करो and share to your friends and call them up. By the time you solve this question also. Very good. This one, all of you make it right. Very good. Very happy. A COPD patient has a history of smoking present with respiratory symptoms. High resolution CT scan shows pan-acinar emphysema. The moment you see this pan-acinar emphysema, the answer becomes alpha 1 antitrypsin deficiency. Emphysema is not a very difficult topic. एक शॉर्ट में डिस्कस कर लेते हैं. देखो, emphysema, asthma, chronic bronchitis and bronchiectasis. Actually, these are 4 obstructive diseases. Okay, there are 4 obstructive diseases. Okay. Now, among these 4, first of all, you should know which is called as pink puffers. ये है pink puffers. It is called as blue bloaters. Okay. Now, among these two, these all, which is irreversible? Irreversible, reversible, irreversible, irreversible. Which part they involve? Acinus. But these all bronchus, bronchus, bronchus. Clear? Now about the finding. देखो, emphysema, we should remember something, a very important mechanism for emphysema is referred to as a air trapping mechanism. Okay, basic pathophysiology is air trapping. So air trapping mechanism in which the air goes inside the acini, gets trapped there and unable to come out because of the destruction of recoil capacity of the acinus. Emphysema classification can be centriacinar, or can be panacellular. Central acids seen in smoking involves the apex of lung, and pan acid is due to alpha 1 antitrypsin deficiency. It involves basically the base of lung. Among these two, central acid is more common emphysema. Asthma often shown in sputum microscopy 3C, 3C, 1, 2, and 3. The first C you expect is Crayola body, second is Kirschmann spirals, and third C is Charcot Leyden crystals. Okay. Along with this, there's a remodeling of bronchus. This is sputum microscopy. Along with that, there is a remodeling of the bronchus. In chronic bronchitis, you expect to see is increase in the read index. Increased read index of more than 0.4. Along with this, we also see squamous metaplasia. We often see also squamous metaplasia. Okay, Achha. Now about the bronchiectasis, what we expect to see is a dilated plus destroyed bronchus, dilated plus destroyed bronchus, and along with these things, we also get the pus. Okay, the sputum microscopy, sputum often show culture positivity. The main etiology for this one is infections. The infection can be direct infections like Pseudomonas, Klebsiella, Haemophilus influenzae, Escherichia coli, TB, Staph aureus, or can be congenital. Among congenital, do not forget cystic fibrosis, Carter-Jenner syndrome, and Young syndrome. These three are very, very important. Okay? This is what you should know in short about the 4 obstructive lung disease. Obstructive lung disease. Okay? Next question. Chalo. This one. Very good. D. The patient has low hemoglobin, low platelet count, which is expected in acute leukemias. But now the question giving you race PT and APT. Race PT and APT is a diagnostic feature of DIC. Okay. So now if a patient has a finding of DIC along with low hemoglobin and low platelet count, along with the blast smears, okay, the image is missing here though, but yes, the image will show you this type of cells like this with a large nucleus, and along with that have plenty of OR rods. Okay, this type of cells being seen with plenty of AUER OR rods can also suggest DIC and is seen in APML, acute promyelocytic leukemia, APML. So the answer is PML rara. I'll discuss here in short about the acute leukemia's main findings. ठीक है, देखो. First of all, you should remember that whenever you get a question of acute leukemia, how you must proceed with diagnosis. देखो, the first thing you should always do in acute leukemia is start with CBC plus a peripheral smear. Okay, a CBC with a peripheral smear will show you some blast counts. Okay, now look at the blast percentage. The blast percentage, is it more than 20%? Very good. Less than 20%? Now you should proceed on to do a bone marrow aspiration oblique biopsy. And then you again count the blast percentage. Okay. Now see whether it is less than 20% or more than 20%. Okay. देखो, if the patient has more than 20% blast in the peripheral smear or more than 20% blast in the bone marrow, it's same only. And therefore these two conditions would be short be called as acute leukemias. ये है acute leukemia. However, if you're suggesting, if you're thinking that the blast count is less than 20%, but you're thinking it can be acute leukemia, in that case you must do the FISH analysis. If the patient has translocation of 821, 1517 or 1616, it is referred to as AML. अब देखो 1517 is PML RARA. Okay, 1616 and 821. 821 has a mutation of RUNX and RUNX T1. Okay, 1616 is CBFB and MYH. CBFB and MYH mutations. ये clear हो गया? Now comes the second point. Second point क्या है? The second point we should know here is, if the patient supposedly has more than 20% blast and you think it's acute leukemia, how we should proceed with diagnosis right now? So for this case, you can first do cytochemistry, which means staining, and finally we can do flow cytometry and immunophenotyping IPT. Acha, cytochemistry mein some stains become very important. What stain we should know? The stains we should all be aware of is myeloperoxidase MPO, Sudan black B, SPB, PAS and NSC. Now remember how to solve the MCQs. So if you get a question of the myeloperoxidase, okay, Sudan black B, PAS or NSC, now look at what can come positive. If you're getting positive for this one and this one, it should be a myeloblasts, I'm writing myeloid cells. Even coming positive for PAS, it can be lymphoblasts. Okay. Now, do remember the PAS can also come positive in erythroblasts and also in megakaryoplasts. Okay, and the third category is about the monocytic blasts. The monocytic blast will have a very strong positivity for NSC. This is how you must solve the question for cyto. ये सब क्या है sir? These all are the question for cytochemistry. ऐसे. Now comes a question for flow cytometry and IPT. मैं CD marker. Sir ये बड़ा tough लगता है. I will make it very easy. The first thing you should see in a flow cytometry or IPT is what of the CD marker are given to you positive. Do remember one thing. If the CD marker given to you is CD34, it means it is blasts. It means it is blasts. ठीक है, देखो. For the flow cytometry, adding it here, FCM. The first thing you to see is blast cells or mature cells. Please समझो इस बात को. This make all the concepts very clear. If its blast cell will be 34 positive, mature will be 34 negative. If the mature cell is white blood cell, it will be CD45 positive. Okay. If the blast is especially lymphoblasts, if lymphoblasts, then we'll be showing you TDT positive. So 34 positive is for all blasts, lymphoblast specially shows TDT positivity. TDT positivity. Okay? Now, once you're done with the blast marker positive, now see which is the other marker given to you. If the marker given to you is CD19, CD3 or CD16, if the answer is 19 positivity, it's a B ALL, 3 then T ALL, 16 then NK ALL. However, if the question is giving you TDT negativity but 34 positivity, then they would give you actually MPO positive with 13 and 33 positive. If this is the thing given to you, ये सब ऐसे, then it becomes AML. बोलो, any difficulty right now? कैसे देखना है सर? 34 पॉजिटिव है ओके. नेक्स्ट पॉइंट, TD पॉजिटिव है ओके. नाउ वी डीलिंग विद द केस ऑफ ALL, बट द क्वेश्चन इज विच ALL सर. ये पूछते हो ना सर, विच ALL. इफ दीज टू आर देयर, ये ALL बन गया. नाउ लुक फॉर विच ALL. 19 है BLL, 3 है TLL एंड 16 है NKLL. If the question is giving you TT negative 34 positivity with MPO positivity, ये क्या बना? AML. It becomes AML. If the question is 34 negative 45 positive, is not at all a case of acute leukemia, dealing with a case of chronic leukemias. It is not acute leukemias. ठीक है? तो in this case it can be lymphomas. This can be lymphomas. तो again in same way, 19 positive B lymphoma, right? लिख देता हूं मैं 19, 3 and 16, correct? It becomes, all of them are what? Not acute leukemias, they are lymphoma. Which lymphoma? B non-Hodgkin lymphoma, T non-Hodgkin lymphoma and NK non-Hodgkin lymphomas. बोलो, clear हुआ सबको? Now if you have any doubts, do ask me right now. अभी पूछ लो. बोलो, कोई डाउट है? डू आस्क मी राइट नाउ. क्लियर है? थम्स अप. चलो नेक्स्ट वन. The answer is yes, D, Burkitt lymphoma. अब देखो, the question giving you 10 positivity, 19 positivity, 20 positivity and is TD negative, correct? Because it's TD negative, it cannot be acute leukemia, correct? Because it's 5 negative, it cannot be mantle cell lymphoma. Are you getting the point? Why not this one? Because this should be TDT positive. Why not mantle? Because it is 5 positive. Now we are stuck with two options, DLBCL and Burkitt's. Actually, this both show 10 positivity. Both show 10 positivity. So, how to say is DLBCL or a Burkitt's? Two things are given in this question which helps us to say is Burkitt lymphoma. The first one is the age. Okay, DLBCL occurs in adult. This occurs in children and adults. The second thing is the image. In the image, look at the cytoplasmic vacuoles. Cytoplasmic vacuoles in a case of a bone marrow aspiration is very important diagnostic hallmark finding of Burkitt lymphoma. So these all given right now in front of you is cytoplasmic vacuoles. It's seen in the case of Burkitt lymphoma. Burkitt lymphoma. Okay. This means, sir, give us a easy trick to solve all the questions for lymphoma. Is right? Is that exactly your question? Sure. So first of all, let's see how to solve a question on the non-Hodgkin lymphoma. The non-Hodgkin lymphoma question can be solved if you get CD19 positive. I'm reading B non-Hodgkin lymphoma, okay? 20 positive with CD45 positive. Do you remember? TDT and 34 must be negative. Only then you can call this a lymphoma. Okay? Once you're done with this part, now we have to say which lymphoma it is. So for understanding this part, we'll see the non-Hodgkin lymphoma can arise from different areas of the lymphocytic development. Just to make the things easy for you right now, the lymphocyte they are all manufactured in the bone marrow, correct? From the bone marrow, they come out into blood, and when they come out into blood, we call them naive B cells. क्या कहते हैं? Naive B cells. Then what happens? They enter lymph node. So I think I'm not making sense to you if you don't know the structure of this. Let's see a lymph node structure as well. देखो. Lymph node histology देखते हैं. देखो. So let's look at this image. ये एक basic lymph node cut section है. Look at this follicle दिख रहा है? ये follicle है. This is all follicle. This is a follicle. Now I'll enlarge one single follicle right now. चलो. So I'll enlarge one single follicle which is this one. अब ये देखो. In the single follicle, look at this centermost area. दिख रहा है? This round area. It is called as GC. GC होता है germinal center. Okay. Around GC, look at the dark band of blue cells. देखा cap जहाँ cap लिखा हुआ है. This dark band of blue cells. It's called as mantle zone. Mantle zone. Okay. And around mantle zone is a marginal zone. Okay. So what happens when a lymph node moves or lymphocytes moves out from the bone marrow? It straight away enters this lymph node. How it enters? It first enters this dark staining mantle zone. Okay, mantle. From mantle, it enters inside and goes into GC area. And from GC area, it comes out to make the marginal zone. What happens? Tumor of the lymph node can arise from any of the areas. It can arise from this mantle zone. It can arise from the germinal center. It can arise from the post-germinal center. समझ में आ रहा है? Please समझो. All your lymphocytes are manufactured in bone marrow. Okay. From bone marrow, they will come out into blood. We call them naive B cells. क्या कहते हैं? Naive B cells. From the naive B cells, they enter the mantle zone. Mantle. सुनो ध्यान से. Mantle. From mantle, they enter GC. From GC, they come out into post-GC area, also called as marginal zone. What happens? Different lymphomas arise from different areas. Okay. So, let's take this image here and put this image in my notes here. यहाँ पर. अब देखो क्या होता है. See. What basically happens is, once the cells have come out from the bone marrow, they come out into blood. Okay. Then from the blood, they enter the lymph node. They enter the mantle zone first. They then enter the GC area. Then they come out into post GC area to become memory B cells. Memory B cells, and they also make plasma cells to make antibodies. Now this is where I want all of you to become super attentive. देखो, mantle zone area has 5 positive. GC has 10 positive. Post GC has 23 positive. Plasma cell has 38 positive. Now, the tumor which comes from the mantle zone, this is referred to as CLL. From GC, what arises is diffuse large B cell lymphoma, Burkitt's lymphoma, and follicular lymphoma. The post GC area, it is what give rise to the CLL again and marginal zone lymphoma. Memory give rise to the hairy cell leukemia, and plasma cell give rise to multiple myeloma. Mantle zone से also what can come is mantle zone lymphoma. So Ranjan, it's not mental, mantle. Okay, so now what happens that when you look at the CD markers, in CD marker it is 19, 20, 45 is a common marker to all the lymphomas. Okay, along with this, if you get a question having 5 positivity only 5, it becomes mantle zone lymphoma. But if you have a question of 5 and 23 both, it becomes a question of CLL. Okay, if the question is 19, 20, 45 with 10, you have DLBCL, Burkitt and follicular lymphoma. Clear? If you have a question of 19, 20, 45 and 38, it becomes multiple myeloma. Answer solved. How to solve a question of lymphoma? First see if you can get these markers or not. If these markers are given positive, look at the other markers. 5 positive, only mantle zone lymphoma. 5, 23 both, CLL. 10 positive, DLBCL, Burkitt, follicular. 23 only, marginal. 38, multiple myeloma. Sir, छूट गया एक, hairy cell leukemia. Hairy cell leukemia, it has unique CD markers, doesn't come into any concept, somehow you have to remember this only. The hairy cell leukemia marker is CD25, 103 and 11C. It also has a marker called as FMC7. The unique markers they have 25, 103, 11C and FMC7. Okay, the basic things that you must remember in a question that is often asked for topic of lymphomas. Bas. बोलो, सिंपल एकदम. तो कैसे क्वेश्चन बनाना है? 19, 20, 45 पॉजिटिव मिल गया. ओके सर, इट इज लिम्फोमा नाउ. यस, लिम्फोमा है. करेक्ट, वेरी गुड, थम्स अप. सर 19, 20, 45 के साथ आई हैव गॉट 5 पॉजिटिव, ओनली 5. यस, क्या होगा आंसर? मैंटल जोन लिम्फोमा. ओके सर, 5 एंड 23 बोथ. सर CLL 19, 20, 45, 10. DLBCL, Burkitt, follicular. 19, 20, 45 के साथ 38, multiple myeloma. So I have made remember this all. You can remember one. Here is a leukemia. What is the marker? 11C, 25, 103, FMC7. Solved. Khatam. Don't discuss more than this. It's enough. Achha. Now sir, can we be asked some other question also? Yes. Some extra question and marking it separately below this. Dekho. The first question that you should remember here is that what is the biopsy finding? Dekho. If the question is on CLL, the question will give you either a convent girl appearance plus smudge cells. Okay, I'm giving you only the main question that can be asked. Okay, second question can be asked on the Burkitt's. So in Burkitt's, in the bone marrow aspiration, you can get cytoplasmic vacuoles as given in the question above. Plus they can show you a starry sky appearance. Starry sky appearance. Starry sky appearance. Okay. The third one is the question that can be asked only. I'm discussing that only. Okay, is the here is a leukemia. This shows fried egg appearance. And about the case of a multiple myeloma, we can get Hoff flame cell, MOTT mott cells, Hoff flame cell mott cell, Dutcher body and Russell body. Dutcher body and Russell bodies. बस इतना तो याद कर ही सकते हो यार. This is what you must know about lymphomas. इतना पढ़ के चले जाओ. All question can be solved from this part. ठीक है? Can we move next question now? चलो. Yes. So answer is B. Very good. देखो. So what is the question giving you? The question giving you 3 chromosomes here, and the question giving you on the chromosome 15th, okay, chromosome number 15, long arm Q, and at the 13th loci. Normal has everything normal, obviously. What you see is a paternal deletion on chromosome 15 here, and paternal deletion along with what you see is a maternal disomy. So when you get a question of paternal deletion or a maternal disomy, it becomes a question of Prader-Willi syndrome. Okay, Prader-Willi syndrome. So what is basically this whole story? देखो. Basically what happens, this whole story is about gene silencing. Okay. Also called as imprinting. Now, what are these two? These two things becomes a question of epigenetics. What is epigenetics? अब देखो, what does Mendel law say? Mendel law, it said that if there is a allele on a chromosome, it should express. Simple logic. But what happens sometimes, alleles are there in chromosome, but they don't express. समझ में आया? नहीं समझ में आया. किसी को समझ में नहीं आया. Hence the name was called as not genetics, epigenetics. Genetics के ऊपर की बात है. No one understood this. Yes, it's how it was named. Okay. So what is epigenetics right now? Basically, it refers to preferential expression of genes from either parent. ये है epigenetics. Okay. So either the paternal gene will express or the maternal gene will express. Both will not express. What the point? How will this happen? Let's see that. देखो. What happens many times is the mechanism for this whole story is hypermethylation and hypoacylation. Can also be caused by something called as histone modification. Okay. What happens because of the hypermethylation, hypoacylation, or histone modification? The three things can silence the gene. Okay. It is seen that on chromosome 15, long arm Q and the position 13, there already is a silencing of a Prader-Willi gene from pattern chromosome. Okay, there's already a silencing, sorry, of the genes of the pattern chromosome and matter chromosome. But this silencing gene is a normal mechanism. Okay, after this, the disease would appear in two conditions. If there is deletion, that means silencing gene is a physiological phenomenon. It's not disease phenomenon. Problem occurs on deletion. So if you see deletion of the paternal chromosome, if you see deletion of the paternal chromosome, it is called as Prader-Willi syndrome. And deletion of the maternal chromosome, it's Angelman syndrome. Got the point? Deletion of paternal chromosome, Prader-Willi syndrome. Deletion of maternal chromosome is Angelman syndrome. How to remember? देखो, P for paternal, P for Prader-Willi, M for maternal, M for Angelman. Okay. There's one more way how it can happen. The second mechanism is uniparental disomy. So what is this condition? It's a condition where both the chromosomes are derived from same parent. Both chromosomes from same parent. Example, if you are seeing a child having chromosome 15th from paternal side only, we'll call this paternal disome. Otherwise, we'll call this maternal disome. Just remember one thing, if the question is of disomy, this whole thing will reverse. Reverse means what, sir? If the question is of paternal disomy, answer becomes Angelman syndrome. If it's maternal disomy, it becomes Prader-Willi syndrome. Just remember, you use the mnemonic P for P, M for M only when the question is of deletion. When the question is of disomy, reverse the condition. Again, understand me. If the question is of deletion, then use the mnemonic P for P, M for M. If the question is disomy, reverse कर देना है. Based on this finding, let's come back to the previous question. यहाँ देखो क्या दिख रहा है. You're getting paternal deletion, maternal disomy. तो deletion के लिए P for P is the mnemonic, right? If it is paternal deletion, what is it? Simply a case of Prader-Willi syndrome. So simple. So the answer is Prader-Willi syndrome. Okay. So what is the Angelman syndrome? This would be because of maternal deletion or can be due to a paternal disomy. So if you now ask me, sir, in every patient do both phenomena occurs? No. In some patient is only deletion, in some patient there is disomy. Which phenomenon is more common? Deletion is a more common phenomenon. Deletion is a more common phenomenon. ठीक है? अच्छा. Now, Cry-Duchat syndrome. This one is a micro deletion. याद रखना. It's a micro deletion of 5 longa. Sorry, 5 shorter. Cry-Duchat. Okay. And Rett syndrome, actually, it's a X-linked dominant disease. Okay. So now I have one question. सर अगर क्रोमोसोम 15q13 अलील फिजियोलॉजिकली ही साइलेंस हो जाता है तो दूसरा तो काम कर सकता है ना डिलीशन में? हाँ करता है, तो बिल्कुल करता है. बट देखो then we have to just go into details of this. देखो what happens is the two genes on the paternal side, I'll just take I don't want to go into that detail, but since you asked me this question, suppose ये पैटर्नल क्रोमोसोम है और ये मैटरनल क्रोमोसोम है, ठीक है. अब व्हाट हैपेंस, ये पैटर्नल है मैटरनल है. फ्रॉम द पैटर्नल क्रोमोसोम द जीन विच गेट साइलेंस is Angelman silence. Angelman gene gets silenced. Okay, because silencing है and making cross mark. ये ऐसे cross mark कर दिया. Okay, whereas from the same chromosome, the parallelized gene is still active. I'm putting a tick mark here. Opposite thing happens in the maternal chromosome. Opposite thing happens in the maternal chromosome. देखो. In this case, what happens? The parallel gene, PW gene, has got silenced, whereas the Angelman gene is still active here. तो your question is what? तुम क्या पूछ रहे हो? Your question is, सर, अगर अलील जो है वो फिजियोलॉजिकली साइलेंस हो जाता है तो दूसरा तो काम कर सकता है ना, ये कहना चाह रहे हो ना? तो मतलब क्या हुआ? सपोज नाउ आई आस्क यू दैट द Prader-Willi gene is actually being expressed by which parent? You'll say sir pattern chromosome. अब सपोज द pattern chromosome is ये जो क्रोमोसोम है, इफ सपोज डिलीटेड, मैं डिलीट कर देता हूं इसको. देखो, आई हैव डिलीटेड दिस जीन, ये गया, गॉन, हो गया डिलीशन. अब नाउ टेल मी हु विल एक्सप्रेस Prader-Willi जीन? नो वन, बिकॉज मैटर क्रोमोसोम में तो वो पहले से ही साइलेंस था. देयर इज नो वन टू एक्सप्रेस इट, एंड देयरफॉर व्हाट डिजीज विल हैपन? Prader-Willi syndrome will happen. Got the point? इस तरह से if the maternal chromosome में if this part gets deleted, देखो यहां पर ये गया, तो who will express Angelman syndrome? Who will express? No one. क्या हो जाएगा? Angelman syndrome हो जाएगा. क्लियर हुआ? हाँ, अब समझ में आया मिस्टर फूडी को. वेरी गुड. फूडी अपना सही नाम बता दो यार. चलो, नाउ वी हैव टू नेक्स्ट मूव टू नेक्स्ट क्वेश्चन. बताओ. चलो आंसर. Yes, the answer is von Hippel-Lindau. Very good. von Hippel-Lindau. देखो, अब देखो what happens is we have a VHL which is due to chromosome number 3 short arm loss. Okay, अब VHL is von Hippel-Lindau. I would recollect this by using a mnemonic Hippel. H is hemangioblastoma. Okay, which is actually nothing but a CNS hemangioblastoma. I is increased risk of RCC. And which RCC? पढ़ाया था इसके पहले, clear cell RCC. Clear cell RCC. Next is pheochromocytoma. Next P is Port-Weinstein is the eye and L is a lung cyst. Eye lesion or eye cyst and the lung cyst. Simple enough. So hemangioblastoma, increased risk of RCC, pheochromocytoma, Port-Weinstein, eye and lung cyst is von Hippel-Lindau syndrome. Okay. Now the question is, look at this question here. Patient को हो रहा है left flank pain, hematuria, weight loss, headache, nausea, convulsions. ठीक. A family history of brain tumor and kidney tumor is present. An MRI shows cerebellar mass. क्या है ये? Hemangioblastoma of the brain. कहाँ का? Cerebellar hemangioblastoma. ठीक है? Along with that, this history is of RCC. There is cerebellar mass. Okay? This whole thing points towards von Hippel-Lindau syndrome. अब ध्यान रखना, ली फैमिली syndrome is due to a P53 familial mutation. Familial mutation. It has a condition of blasts. Simple है, blast. Where B is breast, brain, bone. L is lung, A is adrenal, S is skin and stomach, and T is a tumor. That's a Lee-Frommey syndrome. Tuberous sclerosis is, I hope you all remember, the very famous way of remembering tuberous sclerosis is actually the ash green patches, the tubers in the brain, which is one of the common cause of convulsions or scissors, but has a very important skin lesion called as ash green patches. And NF has NF1, NF2. NF1, if you recall, they have skin lesions again, and a very important skin lesions that you often expect is a cafe a la spots. There is axillary freckles, and then there is also the tumors which can occur as the nose space mnemonic. If you remember the nose space mnemonic, and it's neurofibroma, it is optic nerve glioma, it is sphenoid bone dysplasia, there's plexiform neurofibroma, there is axillary freckles, there's cafe a la spots, and a very important eye lesion, Lish nodules are skin present on the iris of the patients. ठीक है, ये है NF का way to remember. So next question. Next question, guys. Yes, is recruitment of neutrophils. Very good. देखो, patient has COPD, presents with now ARDS, and now this patient is asking you IL-8. So basically, remember, the IL-8 is a chemokine, and the basic function of chemokine is the recruitment of neutrophils. I'll just discuss in short what happens in ARDS. Very, very simple way. देखो, suppose I draw a alveoli, okay, like this. And below the alveoli, I'm drawing a pulmonary capillary like this. ठीक है? Now, on one side, this is the lining of the type 1 pneumocytes, okay? And between them is a type 2 pneumocyte like this. Chalo. Now what happens? The injury activates the macrophage of the macrophage, I'm writing MAC MAC. The macrophage would release IL-8, 1, 6 and TNF-alpha, which would go and activate neutrophil in this part. ठीक है. The activation of neutrophils will first go and damage the endothelium. Because they damage endothelium, what leaks out from this part is fluids. There is a fluid exudation, and hence this whole area has edema. This whole area has edema यहाँ पर ऐसे, ठीक है. Is referred to as alveolar edema. We call this alveolar edema. ठीक है. This whole part is called as edema in the alveoli. ये वाला part. Okay. Now, because it's not due to the cardiac origin, some patients also are referred to as non-cardiogenic pulmonary edema. Okay. Then what happens in some time, fibrin leaks out. Okay. Fibrin leaks out. Now, fibrin leaking out will also leaks out and will go and deposit in this part. Whereas the neutrophils, because violate, are chemo attracted into this part. Neutrophils will now damage the type 1 pneumocystis. They release protease, and the protease function is to damage the type 1 pneumocystis. Okay, they'll damage type 1 pneumocystis. Because they damage type 1 pneumocystis, this whole pneumocyte is getting damaged like this. But remember, type 2 right now is intact. But because of type 1 damage, the patient now has respiratory distress, giving it a name of ARDS. Giving a name of ARDS. Okay, giving it a name of ARDS. Okay. What happens now? The fibrin protein will leaked out. All the protein of fibrin nature would actually go and deposit into this part. Fibrin will go and will deposit into this part as a pink color assay. This pink color deposition is referred to as hyaline assay. This pinkish deposition in this part is hyaline. So if you ask me, sir, what is hyaline? Do you remember type 2 pneumocystis were intact here. The damage was basically of type 1 pneumocystis in the initial stage. Okay, so this one is what? It's hyaline. Hyaline basically is what? It's a damaged type 1 cells with leaked out fibrin. It's a type 1 damaged type 1 cells plus fibrin. This is a basic pathophysiology of ARDS. Very simple, and everything has been discussed here. देखो कैसे injury stimulates macrophage release 816 alpha, which activates neutrophils, damages endothelium, and now what also happens is a chemo attraction into the neutrophils, which release protease, damaging type 1 cells, causing respiratory distress, ARDS. Now, because of the leaked out fibrin will deposit on this alveoli, causing the hyaline deposition. What is hyaline? It is a damaged type 1 cells with fibrin deposition. The question can also ask you, what are the stages of ARDS? In the stages of ARDS, the first stage is exudative stage. The second stage is proliferative stage, where you see proliferation of the intact type 2 cells. Again repeat, type 1 cell damage हुआ था, type 2 is intact. However, if the injury is very severe and type 2 is also damaged, होता है ऐसा, in that case the only way to repair is fibrotic stage. Okay, so in type 2 pneumocystis still till the time it is intact, the proliferation can occur and can again relay a new type 1 cells, and there will not be any fibrosis. However, if they go to third stage, then what happens? Type 2 is also gone. In then that case, what happens? Repair occurs by fibrosis. Exudative, proliferative, fibrotic are the three stages you expect for ARDS. Are three things you expect for ARDS. ठीक है, चलो next question. Okay, chalo. So the answer is B. Why B? देखो, free serum iron toxic to cells is very true. Why? Because it leads to something called as Fenton's reaction, and Fenton's reaction is a main cause for production of free radicals. Okay, iron is stored in the body in the form of ferritin. Is it true? Yes, it's true. Okay. Now the third answer. Serum ferritin donates the iron level in the body. And fourth, iron is transported by binding to apoferritin. No, transportation occurs not by apoferritin, it occurs by transferrin. Okay, and yes, the serum ferritin denotes the serum iron level in the body. That's also is a true option. Let's understand in short what does the question mean. देखो पहले discuss Fenton's reaction. So actually, Fenton reaction is a very important one. It tells you that Fe2 plus with the H2O2 can react reversibly to form Fe3 plus and OH dot minus. Okay, that's the first thing. Now, what happens is in Fenton reaction, the 2 plus is going to 3 plus. How to remember? I remember this as 2 plus, 3 plus, minus 1. If these two balance to become 2 plus. 2 plus 2 plus becomes very easy. So Fenton reaction, remember, is a reversal reaction which says that iron can produce free radicals, and because iron can produce free radicals, what happens? If you recall, this increase in the iron, because they produce reactive oxygen species, they lead to lipid peroxidation and can lead to cell death by necrosis. Such type of necrotic cell death is referred to as ferroptosis. This type of necrotic cell death is referred to as ferroptosis. Okay. This type of necrotic cell death is referred to as ferroptosis. Okay. The second thing we should understand is how is the iron transported. ये थोड़ा सा important है. I'll just discuss in short. So let's say this is GIT part and ये है the tissue part. Okay. So in the GIT, suppose this is the villi of the duodenum. The Fe2 plus, Fe2 plus, it can be absorbed directly by DMT1, divalent maltransporter 1, DMT1. Now 2 plus is now stored in the form and binding to ferritin. याद रखना, the storage form is always 3 plus form. So no, storage and transport occurs in 3 plus form. The absorption occurs in 2 plus form. Absorption 2 plus, storage 3 plus. So this basically is actually a mucosal ferritin. Now understand what is ferritin. So ferritin is actually a combination of apoferritin and iron. Please समझो. Apoferritin plus iron, this whole thing is called as ferritin. And therefore we say that ferritin is a adequately mentioned form where we can denote it as iron amount in the body. If the ferritin is high, it means iron is high. If ferritin is low, it means iron is low. But are they same? They're not same. It only denotes it. Okay. Now what happens, the other form of iron is taken from the basolateral surface from here by what is referred to as the basolateral transport from here, referred to as ferroportin. Okay. Once the iron comes out, it is now again changed to Fe3 plus form, and 3 plus now, if I make this blue color, is now captured by transferrin in the vessel, transferrin in the blood vessels, and from this blood vessel is now brought to the tissue storehouse. It goes to the bone marrow and also goes to liver. Okay, so in the bone marrow, like this, suppose this is the iron getting stored here. The storage again occurs with the help of ferritin. I'm making this tissue ferritin now. These all are tissue ferritin now. And from this, the iron goes out like this. Okay. The iron goes out from here like this. The iron goes out by ferroportin acid. Okay. The iron goes out by ferroportin. ठीक है. Ferroportin is under the negative control of a liver hormone called as hepcidin. Okay, liver hormone called as hepcidin. Okay, this basic short thing you should remember. So now what you should recall is the absorption occurs in 2 plus form, transport occurs in 3 plus form, storage in 3 plus form. Okay, this is what you all should remember. Okay, now the question often asks us that what will happen to serum iron studies. What happens to serum iron studies? देखो. So remember that in our body, ferritin, please remember one thing very simply, that ferritin is inversely proportional to transferrin, and transferrin amount is equal to total iron binding capacity TIBC. मतलब simple word में ferritin is inversely proportional to TIBC. That's simple way. Okay. Now, if you remember this whole story, recall the other part. देखो, the question often will ask us about iron deficiency anemia, sideroblastic anemia, and anemia of chronic disease, ACD. A point is, the four things will help us to differentiate. One is serum iron, one is serum ferritin, one is percentage transferrin saturation, and one is total iron binding capacity, TIBC. Total iron binding capacity, TIBC. Okay. What happens is very simple. Remember, just think logically. If patient has iron deficiency anemia, what do you expect? High iron, isn't it? If iron is more, there should be high ferritin. Sorry, very sorry. Okay. If the patient has iron deficiency anemia, the patient should have low iron. Very sorry, huh? Low iron. If the iron is low, ferritin should be low. If it is low iron, there should be low transferrin saturation. If the patient has low ferritin, as I told you, ferritin and TIBC is exactly opposite to high TIBC. Now, sideroblastic anemia is exactly opposite. It's basically iron overloading. Exactly opposite. If it's iron overloading, तो क्या होगा? It should be high iron, high ferritin, high saturation. I told you, ferritin and TIBC is opposite, so low TIBC. Clear? Now comes the last part, ACD. What is ACD? Do you know what is ACD? Actually, what happens in ACD is it's an inflammation of cytokines. ACD में it's a cytokine stimulation, especially IL-6. It stimulates liver, and liver increases ferritin. Liver increases ferritin, and liver also increases the hepcidin. Okay, because of high ferritin, there should be low TIBC, and because of high hepcidin, there should be low ferroportin. Simple again now. What happens is, because of this condition, see here, in ACD we expect high ferritin, low TIBC, and because of low ferroportin, देखो यहाँ पर, because of low ferroportin, what will happen? खुद सोचो. If patient has low ferroportin, this is less, so absorption is less. Correct? If this low absorption, the iron in the vessel, ये क्या है? Vessel है ना? What is vessel? Blood iron called serum iron. So serum iron is low. If serum, what I'm trying to say is, देखो, if patient has this iron decreasing, if this one is decreasing below, ये कम हो रहा है, decreasing, if this is decreasing, then absorption is less, so this iron is less. Who is this iron? Serum iron, low, and transference saturation is also low, and therefore in ACD what happens? The patient has decreased iron and decreased saturation. And therefore remember, the treatment of ACD is not iron, never iron in fact. The treatment for ACD is always erythropoietin injections. Okay, we can give ferrous sulfate tablets here, we can give B6 here, and here we give erythropoietin injections. We give here erythropoietin injections. This is a treatment for the three conditions, treatment for these three conditions. Okay, bolo, any doubts in this one? Because this is a very important topic, guys, and this will be always asked in either an FMG exam, or you can remember also NEET PG and NICT exams. This is very important. This part, this is very important. In fact, this question EPO also came in this NICT, and this the whole iron profile is often asked as a question in NEET PG, NICT as well as in the FMG exams. Okay, so this is where I would conclude today's session. Now I'll tell you how should you proceed ahead with your days remaining ahead. According to me, if you have studied from my main notes, that is what you must revise as the main thing there. Okay, so you should try to recall majorly the notes, the main notes. Okay, along with that you should try to look at the PYQs, but right now you should also look at the PYQs explanations, at least of 5 years. When 5 years into 2, there's 10 sessions. GT देना है. Don't worry a lot about GT, but at least give one GT 7 days before the exam. Last GT should be 7 days before the exam. Don't give the GT in the last 2-3 days before the exam. Now in the notes, this notes को पढ़ना है retrograde. Okay, don't read antegrade reading. मतलब any question that has been asked in this PYQ, go back and do retrograde reading of the notes. That means don't start from cell injury topic. ऐसे मत करो. See, in the cell injury, has a question been asked from necrosis? Yes, read necrosis part. Has a question been asked from apoptosis? Go and read apoptosis part. It's a better way. Recall is much better, and you get to know what question has more probability of being asked in the main exam. Okay. Now, sometimes students do ask me, sir, how many number of hours we should study? ऐसा कोई limitation नहीं है. Try to look at the GT and try to improve the GT from the previous one. So in the GT also, if you have done any error, it's better that this error should be at least seen from the main notes. If the main notes have this question, you must see from the main notes. If you don't find in the main notes, do not worry, just bookmark it. And इसको revise करना है. Bookmark करना है और revise करना है, that's it. So what you should do is, notes को at this point of time do retrograde reading. Do not read antegrade, उससे कोई फायदा नहीं होगा. Look at the MCQs, PYQ देखो, and from the PYQ, go and read retrograde. Try to give GT, any error, you look at the notes, if it is there in the notes, if not in the notes, bookmark करो, revise करो. Okay. Now, if you talk about, sir, I feel that I cannot do it. ऐसा नहीं है. You know, before the exam happens, even the first rank feels, यार मेरा नहीं होगा. Just try to believe in yourself. The belief is very, very important that yes, I can do it. Don't look into what can happen wrong. A lot of things can happen right by just studying. The study is more important. If you study well, the whole day feels well. If you don't study well, the whole day feels bad. To ensure you have that commitment, you have that motivation to study, make a proper schedule that I have to study this from 10 to 12, from 1 to 2 I have to study this topic, from 2 to 4 after this topic, write it somewhere. Don't just go wayward in reading. Nahi what happens at the end of the day, you feel you have studied much but not what you wanted, or you haven't studied at all what you actually thought of. So better you write it somewhere, put tick mark, and then move ahead. But do remember, when you make a schedule, make realistic schedules. What happens students do is that they write one day for surgery. अब यार एक दिन में पूरी सर्जरी कैसे पढ़ सकते हो? बेटर राइट इन वन डे ब्रेस्ट सर्जरी, GIT सर्जरी, थायराइड सर्जरी, बस खत्म. Because importantly, you should understand what is your limitations. And now, don't leave any subject. ये सबसे बड़ा प्रॉब्लम होता है. Okay, don't leave any subject right now. Try to understand that every subject is important. You can read less of anesthesia, more of surgery, mid of pathology, but don't leave anesthesia. That's disastrous. At least go to the one shot and read that only. At least read the PYQs, but read that only. But don't leave. Sir, मुझसे तो नहीं होगा ये, ऐसे नहीं करना है. It becomes very difficult to get some marks that can just increase from 147 to 152. यही तो बस एक change होता है ना. That is what is important. This 5 marks, 6 marks, 2 marks difference can be covered only by covering each and every subject. So don't leave a subject. Stay motivated, stay in touch. You can message me on Instagram. My ID is drpraveen_aims. The same ID is also in Telegram and on Instagram. I will share this PDF to you in my own Telegram group, and you can share from there. You can send to others of your friends as well. So with that, we conclude today's sessions. I hope you liked it. If yes, once this video is over, please put your comments below this. It's very motivating to me as well as the entire family of DBMCI who is helping you to achieve your goal in the upcoming exams. Okay, best wishes, take care and stay healthy. Okay, goodbye, enjoy.